Welcome everybody to our third monthly developmental disability rounds. We have the pleasure today of welcoming Dr. Caitlin Cassidy. What's that page for?
Third. You think third?
Well, this year. This November. Well, we had developmental disability continuing professional education round. So the second here at CPRI. And so Caitlin Cassidy is an assistant professor in the Department of Physical Medicine and Rehab.
That's right.
So Caitlin did her residency in London and is the assistant professor in that department and also works at Penn Valley. And one of the nice things I can say among patients I have who have worked with Caitlin, their parents, the worst thing they said is that she is fantastic.
Oh, that's nice.
So many positive comments. So
thank you.
And Caitlin's going to talk to us about Rett Syndrome today.
Well, that was a lovely introduction. Thank you. And thank you for inviting me. I'm very happy to be here and talk about Rett Syndrome. I think it would be an overstatement to call myself an expert in the area, but I certainly am gaining experience as I go. And I'm going to chat a bit today about transitioning to adulthood, both sort of with Rett Syndrome and with other conditions, sort of the general concepts around transition, and then give a little bit of information about Rett Syndrome specifically and sort of the different complications that can arise in that particular condition. And I like taking questions as they come, so if you have anything you want to discuss, then we'll just discuss as we go. And hopefully I do this correctly. There we go. Okay, so our objectives today, so we're going to list the key features of Rett Syndrome and develop a general treatment approach for them, describe the challenges facing young adults with coexisting physical and developmental disabilities as they enter adulthood, and list strategies to ease the transition to adult care, and not necessarily in that order. These things will sort of come up as we go. Oh, this is very touchy. There we go. So part one, we're going to talk about the transition to adult care. And so I just put here, why is it such a big deal? And I think probably we don't need to talk about that much. You probably see all the time why it's such a big deal. As one of few people on the adult side who see patients who are sort of quote unquote post-pediatric, maybe I have to talk to people more on that side about why it's such a big deal. And I just kind of, I just have listed a couple of things here to kind of point out some of the things that I see frequently among this patient population. So there's huge differences, obviously, between the pediatric care system and the adult care system. And sometimes people on one side or the other are only aware of the things that are in their own system. So I bring this to everyone's attention on both sides of the divide to try to highlight to people maybe what they don't know about where they're sending people or where they're coming from. So on the pediatric healthcare side, things are often family-centered with significant family and parent involvement, and parents are typically the main contact person. So if you're trying to book appointments or schedule things. On the adult healthcare side, obviously that's very different. It's more patient as opposed to family-centered. Practitioners are not accustomed to parent involvement, and the patient is assumed to be the main contact. So this happens all the time with patients that I see where we call people and say like, hello, can I speak to John? And then we're talking to a parent who says John's nonverbal. And you know, it creates sort of an awkward first encounter, encountering them by phone for the first time. On the pediatric side, there's often significant interdisciplinary support, which is typically much more limited on the adult side, and that just has to do with resource support. So, you know, on the adult side, patients, whether they're post-pediatric or not, are competing with everyone aged 18 to 105, versus on the pediatric side where they're competing from 0 to 18, right? So there's just a much smaller percentage of the population, and so relatively to us anyway, the pediatric side is resource rich, even though we know every part of the healthcare system could use more resources. On the pediatric side, there's an expectation that the patient's family and parent is going to have a major role in decision making, whereas on the adult side, typically practitioners expect patient autonomy, and they expect that the patient will provide their own consent and participate in their own decisions. And obviously that's not realistic in a lot of situations, and sometimes practitioners are just not that well versed in how to navigate those situations, especially if it's not obvious. So if someone's able to converse with you, but maybe not get all the nuances, appreciate all the consequences of their decisions, that doesn't necessarily jump out at the adult practitioner. There's a longitudinal specialist approach to care. I talk about this with people all the time. So people who come over from the pediatric side and are used to having regular follow-ups, whether they quote unquote need it or not. So things are going well, but they still, you know, come in for their annual follow-up or their semi-annual follow-up, whatever that is. On the adult side, it's much more sort of investigational. So you don't need a specialist if the specialist isn't intervening for you directly in the moment. So the specialist will discharge you and expect your primary care practitioner to re-alert them if there's anything that comes up. Transportation can be an issue, so it seems sort of like a silly thing, but we struggle on the adult side with sometimes getting people into their appointments because they don't know how to arrange their own transportation, and parents may or may not be able to come with them. And then maybe sort of an elephant in the room sometimes, especially when I'm talking on the adult side, is the remuneration model. So not always, but often pediatric practitioners are salaried versus adult practitioners who may be more likely to be fee-for-service. And it's quite demanding often to see patients who are from the pediatric world. They have long appointments, they're complex often, and that just doesn't fit into the model of a clinician who's trying to see 30 patients in a day. It just doesn't work. So there's lots of barriers. So system challenges, eligibility criteria for adult programs can be restrictive. There's a lack of equivalent services. So, for example, we're talking about Rett syndrome today. So there is no adult Rett syndrome clinic. There's a pediatric Rett syndrome clinic. And so it just looks a little bit different on the other side. There's insufficient community resources once people are discharged from peds. There's lack of service coordination. People talk about the lack of that one central place to call. So they used to know exactly where to call to talk about anything related to their complex disability, and now they just don't know who that person is. There's developmentally inappropriate facilities on the adult side, and that particularly relates to inpatient stays. So if someone gets admitted and maybe they're 30 years old with a developmental disability and they're in the same room as a 78-year-old who just had their hip replaced. There's insufficient insurance coverage. That's maybe more in the American side, but not totally absent from the Canadian conversation as well. So coverage for things is different when you're no longer covered under a parent's plan, for example. Communication barriers, so there's lack of communication between the pediatric and the adult world, and also, for sure, lack of communication from the adult providers to the patients and families. So we know that we're not good at that. On the pediatric side, sometimes lack of comfort addressing adolescent issues. So some of the articles refer to things like as soon as the patient showed up pregnant, then we knew it was time for them to go to the adult care facilities, just because in some settings that's something pediatric practitioners aren't comfortable addressing. Pediatricians and patients and families on all sides can be hesitant to let go of their pediatric care team, especially if the pediatric care team has been super involved or may have been life-saving on 18 different occasions before they've been before they've gotten to their adult years. Scary to let that go. And then difficulty identifying adult care providers is a huge one that I hear about all the time, and there's lots of reasons for that. So adult providers report multiple reasons for why they're reluctant to get involved, and we've already alluded to some of them. So lengthy appointments and time constraints, lack of transition training and education in childhood chronic disease. So people say things like, this wasn't in my job description. There's a lack of clinical guidelines. Maybe they'd be willing to see someone with Rett syndrome, but they don't know what they're supposed to do with someone with Rett syndrome. And there's, it would take quite a bit of time to kind of educate themselves about that. Lack of remuneration, we touched on. Lack of support from administration, lack of access to services, inadequate pediatric discharge planning or transfer information, especially in places where things don't happen with an electronic record. So even for myself, I work at Thames Valley. When I see someone who comes over to Parkwood, if I didn't see them at Thames Valley, I have to get them to fill out a release of information. They have to send it to Thames Valley. Thames Valley sends me the notes. It's not an easy, fluid process. And then sometimes as well, adult providers describe challenging parental attitudes, so resistance, dependence, things like that, which make it sometimes, again, things that they're not familiar with handling. So key elements that are considered to be important to include in a transition program. So there should be a policy on timing of transfer, and the consensus is that this should depend on developmental readiness, but that there needs to be a guideline for a target age. And that's all fine and good, and we can say that there has to be sort of developmental readiness, but the reality is that people aren't funded to be cared for in the pediatric system past a certain age. So we can give some thought to whether or not they're developmentally ready, but we also just have to know that there's a time that they're going and pay attention to that. Transition preparation and monitoring. So we need to develop necessary skills to navigate the adult clinic where appropriate. So obviously, not every patient is expected to do that independently, but where it's appropriate, we should be thinking about that. And if we're not thinking about it for the patient, maybe we need to think about that for the family. So families need some education about what it might look like on the other side of the divide. Assessment of transition readiness in an effort to address deficiencies is something that's focused on a lot in the literature, and again, is highly dependent on how high our expectations are for patient independence. They suggest keeping a registry of patients nearing transition and think about what tasks need to be done or have been done or are past due. So things like assessing transition readiness, has that been done in someone who's 17? And it needs to start early. So there's lots of different opinions on when it should actually start. This was just one particular survey of parents in New South Wales. There's a lot of literature on transition comes from Australia, and so there was a survey of parents who actually felt that they wanted to start hearing about this from the time the child was 12. So there's a lot that has to go into planning this, and it should start early.
You know, when you talk about a registry, I just think it would be a great issue to have so many. You have to have so many different groups buy into it.
Yes.
And be willing to participate.
Yes.
And I think that'd be the shortcoming. I mean, that I'm not sure the adult, at least for developmental disabilities, I'm not sure the adult system is able wants that, because as far as I can tell, they have a really hard time finding people to see adult patients.
Yeah.
And so it becomes, the idea is great, but how do we actually put that into practice?
So I think, you know, there's maybe a lot of different ways to think about that. So first of all, these are the ideal things, right? So this is what they suggest in sort of an ideal world. And this is all just based on consensus, right? Because there's actually no literature on what the right transition program is. This is just sort of what's been proposed. And depending on what programs look like in different places, because there is no consistency, that can be interpreted in a lot of different ways. So perhaps, for example, in your own practice, if you were able to kind of keep track of who was nearing transition and what you like to include in your transition preparedness, or what you're doing in your planning for transition, that might be something that, you know, you can do in your own practice, whether it involves buy-in from anybody else, to make sure that at least the parts that you can control, you can manage.
What do you guys do?
Usually it depends on which clinic. We'll be honest about it, because there is difference of opinion. But we still start early, 12, 13, and we actually try to have the parents keep that information in a binder, right? So they've got things ready to do the transition.
But do you have some, like, do you include adult providers in that?
Well, we try.
We
try.
That'd be ideal.
We try.
Yeah.
We try.
Yeah.
So, I mean, that's a deficiency in many programs, right? Is that there's a lack of an accepting person. So in the absence of an accepting person, then the recommendations probably are just to do what you can and make sure that you start including the primary care provider early.
Yeah,
so because the family physicians often feel sort of in the dark, and so they receive this person on their doorstep when they're 18, who's had 18 different professionals involved from the time they were born, and now all of a sudden all that specialty care is gone, and the family physician is supposed to take over and hardly knows the patient because they've always been seeing their pediatrician. So it kind of makes no sense. Like we're setting them up for failure, right? So
they don't even always see their community pediatrician. They've got many specialties.
Exactly.
That's
so the primary care person, whoever it is, needs to be involved early, and I think actually that's going to come on the next slide.
The hardest thing is to get parents to go to appointments when they have a number of specialists, to go to a community pediatrician or family doctor when they're well.
Yes.
Like, why would I go to an appointment when they're well?
Yeah.
Right? That is like another added appointment on everything else.
Well, you say, I'll tell you, I see people at the hospital tell me they're with one or other of their kids basically once every few weeks. And so they don't have time just to go to say I'm well.
That's right. Yeah, you can understand. Yeah.
Totally.
In the days of Mervyn Fox and Peter Cameron, I think Mervyn was particularly interested in the adolescents, and I think he also was very active with the adult cerebral palsy. But I don't know how far he kept them in those days.
Mm-hmm.
I'm delighted to hear that there is a person in situ at Parkland identified as looking after the adult cerebral palsy.
We're very happy.
which is a brand new concept from my at the West Side.
But the worry is, at what point is Caitlin become overwhelmed?
Oh, soon.
Yeah.
Yeah. We'll talk about that maybe towards the end. I've put a little bit about my program. Yeah, they do. Yeah. So we'll come back to some of that. So again, more of these key elements that are suggested. So a coordinated transfer process. So joint appointments are very helpful, and we're trying to do that in settings where we're able. Dedicated staff assigned to transition, and this is not actually talking about physicians. So this is, again, going back to that administrative support and buy-in from that piece. So lots of different studies have looked at having sort of a quote-unquote transition navigator. So whether that's a nurse or nurse practitioner, a social worker, maybe not even one of those sort of regulated professions. It could be someone who's just involved in the administrative piece of making sure that those transition elements happen. You need an interested, capable adult service. The administrative support we've talked about, and primary care involvement we've talked about, because it's really unrealistic to expect family physicians to take over multidisciplinary specialty care on their own when they haven't been involved through the pediatric years. So the CPS has some policy statements about how transition should occur, and so I thought that would be maybe useful to throw up here. So transition is a life phase that includes moving to adult healthcare system And that's important. So the definitions are distinct. So transfer is the physical movement from pediatric to adults, and it's a one-time deal. Like the act of transfer is a one and done thing, whereas transition is this life phase that spans that period of time before and after the transfer. Developmentally appropriate care for adolescent patients with special healthcare needs should be integrated into peds and subspecialty practice structures, kind of what we've been saying all along. The goal is to provide healthcare before and throughout the transfer that is uninterrupted, coordinated, developmentally appropriate, and psychologically sound. All sounds wonderful. Recommendations. So we've gone through a bunch of these already. This is just the ones that the CPS has picked out to put into their position statement. So it's ongoing. It begins early and ends sometime after transfer. No one really knows when. Appropriate resources and educational materials should be provided. Planning should be youth-focused with appropriate attention and supports to family members. Transition should occur at the youth's pace, not possible in many situations. Planning should be integrated into existing specialty clinics. So this is a key one, I think, because there has been a lot of talk about just creating quote-unquote transition clinics, which have their place and purpose, but the challenge that they typically face is that then you're just transitioning again, right? So they might see you to talk about transition, but then where do you go from there if there's no specialty adult service to go to? Developmentally appropriate care obviously should be provided, including stepwise plan and increasing responsibility as appropriate, maybe not appropriate. Skills training and communication and negotiation should be provided to enhance navigation in the adult care system. That's, again, ideal, but maybe not feasible in our current environment. And again, maybe should be directed more to the parent and to the child, depending on their expectation of independence. And then importantly, which I love to stress, and I already have, the family physician should be an integral part of the team. So that's sort of the basic transition stuff that I wanted to discuss. And then we're going to talk maybe more specifically about Rett syndrome, which was what I was, asked to address. And then I kind of said, we're going to talk about transition stuff as well. I hope that's okay with you. So now we'll kind of shift gears and talk about Rett syndrome. So Rett syndrome, and again, I do not claim to be a particular expert, but I'm working on becoming one. So when I first started working here, I had a lovely conversation with people at Thames Valley who said, this is great, you have to see our girls with Rett syndrome as well. And I said, sure. And so we're just kind of navigating our way through that. And so, in fact, good timing. I had 3 different girls with Rett syndrome in my clinics over the last 2 weeks. So they were kind of highlighting to me things that I wanted to make sure I included in the presentation. So Rett syndrome is a neurodevelopmental disorder which was first described by Andreas Rett in 1960-something. It's a clinical diagnosis with both typical and atypical subtypes. The genetic underpinnings were first identified in the late 90s by Amir et al. So they identified mutations in a gene encoding methyl CpG binding protein 2, so MECP2. So mutations in that gene of various types are present in 95 to 97% of people with typical Rett and 50 to 70% of people with atypical Rett. And importantly, there are also some people without clinical Rett who have MECP2 mutations. So in a small percentage of people with autism, mutations in that gene have been identified, and perhaps a larger percentage as well of people with Angelman syndrome. It was previously included as PDD-NOS in the DSM-4 and has been removed from the DSM-5, which perhaps you guys know more about than me, but I did have a look at some interesting sort of chat room discussions about that, and I guess there's been a lot of back and forth on how appropriate or not appropriate that is, but in my understanding, it's no longer included, probably because there's this known genetic cause that has identified it as being totally distinct. Dr. Freed. Oh, interesting. Never should have been there.
The people with Angelman syndrome who also have the MECP2 mutations, they also have the Angelman's. Do they clinically have Angelman syndrome, or they genetically have it?
They have clinically. Clinically, they have Angelman syndrome. Actually, that's a good question. I don't know if they have both genetic.
But not in the
Not in
They don't have the 15.
not on chromosome 15?
No.
Thank you.
No.
So typical Rett, the incidence is about 1 in 10,000 and is most common cause of severe intellectual disability in females. It's most commonly a de novo mutation. It's on chromosome XQ28, and inactivation patterns influence disease severity. Also, of course, as we were just kind of talking about before, Dr. Nicholson, there are those differences in the genetic abnormality, and there's a spectrum of different changes that are associated with that. There are rare cases in males that have been identified more recently. Often males die in infancy with severe neonatal encephalopathic presentations, but some have been identified with a fairly typical Rett presentation. The first clues typically present between the ages of 6 and 18 months. And this was just maybe to kind of throw out there what we're actually talking about. So the MECP2 protein is a transcription regulator of other genes that's highly expressed in the brain. And failure of regulation of transcription leads to the altered neurodevelopment. It's also expressed in glial cells, and it's quite involved in sort of synaptic connections in the brainstem and other locations in the brain, which perhaps is very important when we talk about some of the clinical manifestations, in particular things like breathing abnormality. So the diagnostic criteria were revised in 2010. It remains a clinical diagnosis, despite the fact that there is the gene that's been identified. There's a lot of conversation about the fact that the clinical manifestations still have to be met in order for the diagnosis to be made, especially now that we've identified that there are other conditions that can have the same genetic abnormality. So it's thought that the diagnosis should be considered when there's postnatal deceleration of head growth, particularly in young girls, but now we know also in boys. There are, we're going to go through the specific criteria in the next few slides, but in typical Rett, there's a period of regression followed by recovery or stabilization, which is required for diagnosis. They have to have all of the main criteria, which we'll go through, and none of the exclusion criteria, which include brain injury or grossly abnormal psychomotor development in the first 6 months. The supportive criteria are not required, though often present, and that is sort of distinct, of course, from atypical or variant Rett, where they again have to have that regression followed by recovery or stabilization, but then maybe only 2 out of 4 of the main criteria and 5 of 11 supportive criteria, which we'll now talk about. So the main criteria, all of which you have to have for typical Rett, so partial or complete loss of acquired purposeful hand skills, partial or complete loss of acquired spoken language, gait abnormalities, and stereotypic hand movement. So those are the 4 things that you need to have for typical Rett. You have to have 2 of them for atypical Rett. And then the supportive criteria for atypical Rett, so you have to have 5 of 11. So breathing disturbances, bruxism, abnormal sleep, abnormal motor tone, muscle tone, peripheral vasomotor disturbances, scoliosis, growth retardation, small cold hands and feet, inappropriate laughing or screaming, diminished response to pain, and intense eye communication. So eye pointing is the other thing they talk about.
So it means
Yeah, so they tend to make very intense eye contact and like not a lot of blinking, and they use their eyes to point at things that they want. Oh, that doesn't come out that well, does it? It was perfect on my screen, but it doesn't look that great there. So this is just from the Newell et al. Article from 2010 that actually delineated those updated diagnostic criteria. There have been a number of variant forms of Rett that have been described in the literature, but these are the only 3 that are now recognized in the updated clinical criteria. So there's the preserved speech variant, the early seizure variant, and the congenital variant. So we're not maybe going to go through all of this in detail, but the idea is that there are these sort of 3 clinically distinct types of atypical Rett that have some, underlying things that are a little bit more particular. So preserved speech still has the MECP2 abnormality. Epilepsy is much less common. Their intellectual disability is much more mild. In the early seizure variant, it's more likely that they have one of these other mutations. So we talked about how in atypical Rett, only 50 to 70% have the typical MECP2 abnormality. So in these other ones, the early seizure variant is more likely to have a mutation in CDKL5. And then in the congenital variant, where things start to present obviously much earlier, then again, it's a different mutation, so in the FOXG1. And so those are just perhaps other genetic underpinnings to look for if you're seeing these sort of atypical presentations.
Can I comment?
Sure.
I think in some 2,000 adult mentally handicapped, there's one patient that I was convinced was Rett syndrome. Clinically, because I had the regression at the hand wringing, at the spasticity, sent them up for the mutation to Dr. Hagelin's lab, who was the only one doing it, and came back negative. Now I see, I called it, I'm so convinced that I said this was a form plus Rett syndrome. But now I see this Rolandan variant does not necessarily have the mutation. But I found this Nikki Sears, somebody that did say it, and she said, well, if Dr. Hagley didn't find it, then it's not Rett syndrome. This Rolandan variant might have been it.
Could have been, yeah.
So earlier you said, though, that one of the requirements that people have to have a period of normal development,
Yes.
followed by a loss of function. for people under the congenital variation, it said grossly abnormal initial development.
Mhm.
How can that be consistent with having
It's a
normal
great question. And in fact, it seems like there's a lot of debate about that in the literature as well. So even in this,
Regression.
yeah, so even in the congenital variant,
Yep.
there seems to be consensus that although things happen much earlier, there should still be at least some period of normalcy. And even actually in typical Rett, the period of normalcy is now recognized that perhaps there were subtle abnormalities there as well. But the point is that even if things were subtly abnormal, it might just be for a very short period of time in this variant. There should still be a decline.
What are if it's have to do with
Well,
first month of
exactly.
life?
Exactly.
And what
So
is
it's
normal development?
right. So, maybe you can have though up to 4 months before you might see the abnormalities. Like maybe it would be 3 or 4 months or something like that. But again, this is debated.
When you say on for the typical consideration, says mild intellectual disability. When you say IQ up to 50, you mean up to 50 or down to 50?
Well, this is taken right from the article, so I think they mean up to 50. But
So it's not
but
higher
that's
than 50.
not according to this.
I don't know how many have ever been diagnosed.
I know. Yeah, I think it would be genetics claims
Yeah.
now mostly.
Because of the hand function.
Right.
There's more about it.
The
Yeah,
loss
I
of
think-
hand function.
Yeah, and I
The
think
loss
we
of
see-
hand function.
I think we see some kids here, but it's typically ones with more severe behavior problems, as well as so they're not diagnosed typically here. So the girl we have in common, you would say she is atypical?
I don't know who we have in common right now.
Cassidy?
I don't remember who that is right now. I'm sorry. Sorry.
I can probably tell you.
You could, yeah, there you go. Yeah.
Abby Congo?
Mhm.
Abby Congo?
I
Okay, yeah, 'cause I think her mother did say, but her IQ is way below 50. Although it's difficult to assess because of all the.
It's very
variables.
difficult to
I would
assess.
say Abby's is probably higher. Abby's got a computer.
Yeah, she had an
She
incredible
uses
machine.
finance,
Yeah.
And then unlocked, we really know exactly what's going
Which we're going to talk about.
on. And one of the things too about Andy is all people talk about is speech regression.
Yep.
Abby was an example. We see probably in the past, we never had normal language development.
Yeah.
So we presented as language delay. We treated that way when we lost the hand function in the light bulb.
Well, that's because over the years I've had a few patients with 50 Sue who had, not what I would have thought is as typical Rett presentation, and it had really no development. And this is 10, 15 years ago. And figured, said, well, maybe their function was so low they couldn't lose function. But I think in that way it's sort of fudging criteria a little bit. Now, if they have different groups in it makes sense.
And then I just wanted to mention this one. This one's a bit older. So Hagberg is actually one of the sort of early identifiers of a group of patients with Rett syndrome. And this is a very interesting article, actually, published in 2002, giving sort of the historical perspective on Rett. And he had collected a number of patients that he had identified with this similar phenotype and was actually, in the process of discussing this with multiple different people when Rett actually published his paper. And so this is referring to what's been described classically as the different stages of Rett. So stage 1 is the early onset stagnation. So that's sort of where the developmental progress seems to kind of stagnate, obviously, as the stage name would imply. Stage 2 is when things tend to regress, sort of between ages 1 to 3 is when that might start. And then stage 3 is the pseudo-stationary period, which is kind of interesting and very interesting to me as someone who sees them as adults. So this stage can last for many years to decades. So typically, I would say most likely this is when I'm seeing the girls. And then stage 4 is the late motor deterioration, and there's not a lot of consensus about when that starts. You can see the onset is when stage 3 stops. So no one really knows. There's not a lot of consistency potentially to when that might begin. But there is sort of recognition that there is this later stage regression that happens later in life. So the differential diagnosis that I wanted to put here, there's obviously lots of different things that could be considered here, but the 3 that were sort of highlighted particularly in this one article were Angelman syndrome, as we already discussed. So the intellectual disability, severe speech impairment, and gait ataxia might all kind of look very similar in early stages of working through the diagnosis. limb tremulousness and inappropriate happy demeanor. And then microcephaly and seizures are common. CP, of course, especially with that, as we were talking about, Dr. Nicholson, with the more congenital presentation of Rett syndrome, that might be a little bit more confusing if you didn't notice that period of normal development then decline. And then autism spectrum disorder, which, you know, as we were discussing how this was actually included in the PDD-NOS, that perhaps has contributed to some confusion around this, but there's lots of articles written about these, and we'll talk about some of that as we move through the clinical phenotype of Rett, but lots of overlap potentially in some of the presentation of both of these patient groups. So the clinical phenotype of Rett, so I just put this one reference up there, but that's sort of where I took the main categories of what we're gonna discuss through here, and then supplemented by some other resources as well. So we'll just work our way through these. So sleep disorders, disrupted sleep is very common in Rett, either sleep initiation or sleep maintenance or both. So there was this one survey of parents in 2016 where 80% reported frequent night waking, which is more frequent in younger children. And then it was higher risk in those with seizure disorders. There was other features as well, so excessive daytime napping. Oh, there was a delay, sorry. Excessive daytime napping, nocturnal laughter is something that's quite frequently identified. So even though girls wake up in the middle of the night, they're not unhappy, it doesn't appear, they're just kind of laughing inappropriately for long periods of time, which can be unsettling. And then sleep terrors as well. And so I put here, the approach is not magical, so it's not different for Rett syndrome necessarily than it is for other people who have sleep disorders. So you have to assess the problem first and rule out contributors. So frequent ones that are identified in this patient population are reflux, pain, otitis media, and sleep apnea. Sleep hygiene needs to be addressed and is often perhaps overlooked in a population of people with developmental disabilities. So we think, you know, maybe they can't adhere to sleep hygiene recommendations, but you have to consider them first and foremost. And then if all else fails, medication. So that's our last resort. And see, this doesn't come out either. That's unfortunate. I'm not sure why. Again, it looked perfect on my screen at home, so I apologize for that. And you know, the details of this are not important, and unfortunately I can't see it even here on the screen either, but the details are not important. The point is that there are screening tools that you can use. The Bears sleep screening tool is a nice one and was referenced in a couple of the articles, and it just identifies, the reason why it's nice is because the 5 categories that it looks at are commonly the problems in people with Rett syndrome. So bedtime problems, excessive daytime sleepiness, wakings during the nighttime, regularity and duration of sleep, and snoring. So maybe snoring a little bit less, but those other ones are frequently identified in this population. And because it's geared towards pediatrics, it can sort of be used, if you use it in that adolescent time frame, even for people as they're transitioning into the adult world. It gives ways that you can ask the parents the same questions if the person is not able to identify those things on their own. So sleep management in individuals with neurodevelopmental disorders, this one's not specific to Rett because there wasn't one specific to Rett. So sleep hygiene, optimize the environment. So think about noise and light and room temperature, maintain a schedule and routine, and manage physiologic factors like hunger. Medications that could or should be considered. So iron supplementation is an interesting one. So they've identified that low ferritin levels in a population of people with ADHD or autism or periodic limb movements, low ferritin has been associated with worse sleep. So if you identify that ferritin is low in the patient, supplementing that may be helpful, and that's pretty low risk in terms of the other things that you're considering in these populations. Melatonin has been shown to improve sleep latency and modestly improve total sleep time, but we know it's better for improving sleep initiation than sleep maintenance. Gabapentin was an interesting one that has been shown to be somewhat effective in a population of people with neurodevelopmental disorders. You probably don't use it that much unless you're already thinking about using it for some other reason. But then in that case, maybe a little bit more at nighttime might be helpful for sleep. Not particularly recommended, but which we do still use, depending on the situation. So TCAs are not particularly recommended, nor are antipsychotics or chloral hydrate. Another one that's used frequently that I didn't specifically put in here, trazodone is used often and probably is fine at a low dose. There are QT prolongation considerations in the population of people with Rett syndrome, which is why it's not specifically on the list. Cardiac considerations, which is, it's like I just knew that slide was coming next. So the clinical classic feature in people with Rett syndrome is a prolonged QT interval, and so that is something that needs to be considered and looked for. Annual ECG screening is recommended, and then if a prolonged QT interval is identified, beta blockers should be considered, but maybe most importantly, avoid prescribing medications that make the QT even longer. Respiratory considerations. So perhaps, as we sort of alluded to before, these are related to the altered synaptic transmissions in the brainstem that come from that MECP2 abnormality. So lots of different things identified. So hyperventilation, breath holding, air swallows, and apneas are sort of the 4 classic things that are identified. Subsequent hypoxia from these issues may increase bradycardia and exacerbate the QT, so they can kind of lead into each other. So the recommendations here are essentially avoiding medications that reduce respiratory rates, so opioids and benzos. And it's interesting in mice with like MECP2 knockout mice, they've identified that dizipramine, which I just said that we should avoid potentially in people with Rett syndrome because it's a TCA, has been shown to improve respiratory rhythm in mouse models. So that hasn't been translated to human models yet, but just sort of an interesting thing.
Did they try them with other drugs or
Just dizipramine. I have no idea why.
So it's the most noradrenergic. Excellent.
Yeah.
But other than that, I can't think why.
Don't know. Bone mass and fractures. So bone mass is typically reduced in patients with Rett syndrome. The fracture risk is elevated compared to the general population, and they are at high risk for low energy fractures. So lots of risk factors associated with this. So short stature, lack of ambulation, inadequate diet. And then this one comes up a lot and is important for us to consider. These patients often have refractory epilepsy, and there's a number of anti-epileptics that increase their risk of low bone mass. So those are listed there. So carbamazepine, dilantin, phenobarb, primidone, carbazepine, and high-dose topiramate all have been, all of them induce the CYP450 enzyme in the liver, and so that increases your risk of low bone mass. And then valproic acid through mechanisms that have not been well identified, but not through that one. So those are the anti-epileptics that could be contributing to this phenomenon in this population. So the recommendations are basically just to monitor the vitamin D levels and supplement if it's low, or maybe even if it's not super low, but the patient's considered high risk, and especially if you know that they also have poor dietary intake and may not be upkeeping that on their own. Bisphosphonates should be considered if bone mineral density is low and there are fractures. So those 2 things are required in this population to make the diagnosis of osteoporosis. In pediatrics, this is typically managed with pamidronate infusions. In the adult population, maybe there's some more options in terms of different choices of bisphosphonates and oral formulations, but there are risks associated with them, particularly for a patient population who's already at high risk of reflux. They can have a lot of symptoms related to that. And then in the adult side, and I debate this not just in Rett syndrome, but in basically all of the patients that I see who are non-ambulatory with low bone mass, is whether or not treatment should be initiated, and if so, at what age, and if we initiate it, for how long, because we know that longer-term use of bisphosphonates is associated with an increased risk of atypical fractures in the femur, and so we don't want to put them on treatment to avoid fractures and then cause a fracture. So there's a lot of debate, and this is not well determined in terms of what we should actually do. So GI disorders, we'll spend maybe a little bit more time here. So physiologically, there's a lot of reasons why people with Rett syndrome have GI concerns. So they have poor chewing and handling of food boluses in the mouth, irregular gastric and esophageal motility, and reduced gallbladder contractility. So clinically, they have functional challenges with intake. This has primarily been pegged on an abnormal oral preparatory phase. So they're not very good at mastication and sort of propelling the bolus back into the pharynx. But once it gets there, they don't seem to have a lot of pharyngeal dysphagia. Constipation is a major issue, GERD, abdominal bloating, and gallstones, and we'll talk about all of those. So constipation in this population is multifactorial, so management should be multifactorial too. So adequate hydration is an issue in a population of people with Rett syndrome who typically have poor oral intake. We need them to increase their physical activity if able, which is sometimes doable and sometimes not. Upright voiding routine should be considered if possible, especially if the patient cues. So many people with Rett's are not continent of their bowels, but if we can start them on a bowel routine that includes them being upright on a commode for voiding, that increases our success rate. Diet. So we need to think about that rather than, again, just going straight to medication. So I thought maybe this would be helpful. I actually, dug through some dietary literature to help delineate what types of fiber we're looking for. So coarse insoluble fiber essentially mechanically stimulates the colon to be better at moving things along. And gel-forming soluble fiber increases the fluid that is inside the stool to make it softer and easier to evacuate. So there's just some sources that are listed there. And then medications, so the usual go-to medications have been demonstrated to be effective here. So PEG 3350 or PEG Light and milk of magnesia have relatively equal efficacy. and they produce less gas than lactulose. And we definitely don't want to produce gas in a population that already has abdominal bloating. So please don't use lactulose. And then there are, of course, gastric motility agents, but again, long QT is a risk with these medications, so frequently they are avoided. And of course, I didn't put it in there, but if they're completely refractory to oral medications, then there are more invasive procedures that could be considered, but we don't want to do those if we don't have to, and it would be rare that we cannot manage their constipation as long as we actually get on top of it and manage it aggressively enough. And there has to be a lot of education on what we're actually targeting. So with families, I talk about working towards 1 bowel movement a day or 1 bowel movement every other day, and we can sort of increase and titrate our medications up to achieving that. So gastroesophageal reflux, so common clinical presentations: vomiting, rumination, regurgitation, respiratory signs, and perhaps even unexplained weight loss. So investigations has a question mark beside it. The typical thing in this population is just to do a trial of treatment and see if you notice any improvement. So treatment includes small frequent meals, upright positioning during and after meals. PPIs are considered first line. H2 receptor blockers or prokinetics, but again, don't use prokinetics. And then consider fundoplication. Abdominal bloating. So I put this in here. This was not in the article, but we definitely need to consider time out of the wheelchair for people with abdominal bloating. You can't pass gas if you can't get it out. So you need patients to actually get out and perhaps be inside lying or in other positions. And also bed mobility. So think about, tiny kids when they have abdominal bloating and you get them out onto the bed and move their legs around. The effectiveness of medications is not particularly known, but there is perhaps some anecdotal evidence for simethicone or Gas-X and SSRIs. And then, of course, if they have a G-tube for any other reasons, then venting can be done through the G-tube. Gallstones, the incidence is slightly increased in Rett compared to the general population. And essentially, again, there's no magic to this. The management is the same as in anybody else. The point is that you should think about it in someone who's having unexplained behavior changes or pain behaviors, especially if GERD has been ruled out, because GERD is much more common than gallstone. Psychiatric comorbidities are common, so mood and anxiety disorders in particular, but maybe that's less true in the adults. So they postulate a lot in the literature about perhaps this being more of a frequent complication or frequent problem in maybe the pre-adolescent or adolescent girls as opposed to in the adult population. So address the environment. That's important to give time and explanation for changes, especially as we're approaching and going through transition. So we see a lot of behavior changes and tearfulness and things like that when people are transitioned out of school, out of familiar environment. They have to come to a new hospital, see a new doctor. All of those things can be very distressing. Address sleep issues because no one feels good if they're not sleeping. And then SSRIs are considered the treatment of choice if something is required. And again, just like another little fun fact, so we talked about a fun fact about dizipramine. So MECP2 null mice have reduced hippocampal serotonin levels, and fluoxetine has actually been shown to increase MECP2 RNA in rats. So maybe another plug for why an SSRI might be a good choice treatment-wise, not just for their depression, but maybe for their Rett overall. Behavior I thought would be of interest to this group, so we'll spend a little time here. So behavioral profiles. I thought this was actually a really interesting article. They compared 3 different groups. So they compared people who had isolated Rett syndrome, people who had intellectual disabilities, and people who had intellectual disabilities and autism. So they tried to kind of suss out which behaviors were more common in the Rett syndrome population compared to those other groups. So they identified more mouthing and swallowing of objects, more sharing, which of course they see less in the autistic population, more appropriate responsiveness to strangers, failure to use hands purposefully, or they have a restrictive repertoire of hand movement, and they have more repetitive tongue movement and more shyness. Compared to autism with intellectual disability, they have less aggression, they play with their saliva less, they have less hand flapping, less body rocking, and they don't as often do the opposite of what they're told. So less sort of oppositional behaviors.
They are normal for kids too.
With equal frequency, they have unusual play with objects and they react poorly to correction. So, that's with equal frequency in both groups there. Rett compared to autism has greater adaptive and social skills. And, from a behavioral perspective, obviously the preoccupation with hand wringing we've talked about a little bit, and there's debate perhaps about what to do about that in this group. I'm going to skip this one actually and go right. This one worked. Okay. So this was an interesting article specifically about addressing the upper extremity abnormalities in Rett syndrome. So essentially the question is whether or not the hand stereotypies are functionally impactful or self-injurious, because if there's not, it's hard to make a compelling argument to do something about them. If they are, then there are different things that can be done, and it depends what the functional impact or what the self-injurious behavior is, what you should actually institute. So frequently we use these elbow extension orthoses. So essentially we're blocking elbow flexion so that they can't get their hands together and can't bring their hands. There's been small sort of case type report things about that potentially increasing functional hand use. So obviously functional hand use out here though, right? Because we've just stopped them from bringing their hands up to their face. But maybe if the only problem associated with their hand use is that they're constantly scratching at their thumb, maybe all they need is something that protects their thumb. So the intervention has to fit the problem. I still have a lot of slides and not a lot of time. I'm going to talk faster and maybe skip through a couple more things. So epilepsy is very common in this population. The cumulative lifetime prevalence approaches 90%. At any one time, the point prevalence is about 30 to 45%. Interestingly, there seems to be some improvement in this as they come into their adult years. So again, that sort of impossible refractory epilepsy seems like it's more of a problem in the pediatric years, and it, I don't know if flares out is the right word, but they seem to have less difficulty with refractory seizures in adulthood. Risk factors for refractory seizures are frequency of hospitalization, non-ambulatory patients, scoliosis, enteral feeding, and later diagnoses. Communication is an important thing to talk about. Obviously, one of the key features in typical Rett is their lack of spoken language. What do I want to focus on here? So the strategies for managing this are variable. Lots of people use low-tech options. There has been a lot of interest in recent years about use of eye gaze technology to facilitate communication in this group, capitalizing on the classic intense eye gaze, which is common in typical Rett syndrome. So the Tobii eye gaze device is used often. So there's not a lot of great studies on it. I think it's maybe sort of in the emerging literature, maybe more abstracts as opposed to published articles. So this one article looked at a number of Dutch families. So out of a lot of Dutch families, though, 20 were reporting that they were using or had used eye gaze technology. So still not a lot of uptake, at least in that population. I'm not familiar with a survey that's been done in Canada, where presumably it could be different based on access. And this is important, and I see this clinically, so increasing success with longer-term use. So I think this is maybe what we're talking about, how it's difficult to assess intellectual capacity in someone who doesn't have the means to communicate with you. But as this technology is integrated into the life of someone with Rett syndrome, we do see increasing success with communication. And all of a sudden we see, oh, like you can really answer these questions yourself. Like there's a lot of information that you can directly provide to us. And so it's providing a new window and new insight into what their capabilities really are.
I mean, the girl that came and I were talking about has one of these, and it's actually phenomenal. I don't know why it hasn't taken off in people with neurodegenerative disease, but just looking at it, and I don't know how it follows her eyes and what the deal is, but it allows her to pick movies that she wants to watch, or if she wants to listen to a specific song, she's able to do that. I don't know if she can actually spell or not. I don't know if she
Yeah, she's actually uses it to do her schoolwork.
wow.
So she can do like an oral presentation that she's put together on
Which is phenomenal. I mean, I think one said it's on the order of $20,000. It's some staggering amount of money, but over time it'll come down. But it's really incredible technology.
We try all the girls, all the patients with Rett syndrome, we try them on.
And, you know, I just saw someone yesterday who's had the Tobii now for quite some time, and there's been a lot of frustration about getting her to use it reliably. But now that she's had it for a while, and there was a lot of question initially about whether or not she was just accidentally focusing on things with her eyes, because it responds to how long you look at something. And in someone who has intense eye gaze, maybe she's accidentally intensely looking at something. But they've now identified that there's a specific thing that she wants to tell us, and they have buried that particular thing in multiple different spots on the Tobii. So she has all these different pages that she can work through, and she gets to it every single time. Like she is purposely going through multiple pages to get to this particular thing, no matter where they find it, where they hide it. So, you know, we're seeing an increasing sort of rate of success with that.
That will influence our perception of it being the cause of severe intellectual disability.
Maybe, yeah. It's hard to say. And I mean, the technology maybe will change over time and give us a better idea. She is not at the point where she could do things like spell on it. So she's essentially selecting pick symbols. But, you know, there's such a variability there. I don't know. Maybe the sky's the limit. Hard to say. Other things, so vasomotor changes are common, scoliosis is common. Usually we work on that with conservative management. And then movement disorders is something that I wanted to mention because this is the one that they really identify seems to progress with age. So when we talk about that late stage progression in Rett syndrome, it seems to be the movement disorder that's the biggest thing. So gait gets worse and tone gets higher. And there's a lot of sort of conflicting, I'm a physiatrist, so I like to be really specific about this, but some people call it rigidity, some people call it Parkinsonism, some people call it spasticity. These are very different things to me, but it's actually difficult clinically to suss out what the actual presentation is. And there's no evidence that I could find on sort of specific targeted management for that, other than those who've identified it as Parkinsonism have found really no success with using Cinemet. So the adult with Rett syndrome, we're going to skip over that because I've kind of talked about that already. So the seizures tend to be a little bit better, communication tends to be a little bit better, motor phenomena tend to be a little bit worse. And then I don't know much about this at all. So these are about sort of the genetic strategies that are being investigated to directly target and treat Rett syndrome. So we've been talking about symptomatic management, but there are a lot of investigations going on about specifically targeting and addressing the underlying genetic abnormalities. So insulin-like growth factor related complexes, aminoglycoside antibiotics, which read through nonsense mutations. BDNF is the brain-derived neurotropic factor, which you unfortunately can't just give to people, but they're looking at related compounds. And there's some promise with lots of these different things, but there's nothing that we haven't quite hit on the cure yet, which is probably obvious. And we are essentially out of time. I'm maybe just going to say in 2 sentences or less what I do. So the Transitional and Lifelong Care Program is where I work. So essentially it is a program that is designed to take care of adolescents and adults who are post-pediatric. So people who have childhood onset conditions which have a physical disability component, because I'm a physiatrist. So I do see lots of people with developmental and intellectual disabilities in association with a physical disability. And so we are essentially trying to provide prospective treatment and planned participation in a transition care model, and then ongoing care rather than transitioning them again to nowhere. I'm going to skip through these things. I just wanted to put this up for you to show you a little bit about sort of what services we provide. And maybe I'll just leave this here and then we can see if there's any further sort of discussion.
Do you work with psychiatrists?
I don't, but I would love to. So I do refer people as needed to the dual diagnosis program when we have people who have developmental disabilities and challenging behaviors. I'm developing some experience in trying to manage those myself because, of course, the dual diagnosis program is
really fast.
yeah. So they're overwhelmed, right? So the wait to get into those programs is quite long, and their ability to follow them long term is limited. So we make use of them judiciously, and we're trying to figure some things out on our own and doing some different treatment trials. We are, of course, limited. We don't have a behavioral therapist either. So as much as we say that we would ideally like to manage those things non-pharmacologically, and we do that as much as we can and make use of things like regional support associates. Often for safety reasons, when we're talking about, like a 22-year-old 6-foot male, we do resort to medication options, and that's basically because it's what we need at the time.
There is the regional support associate. At contact with them. Yeah,
so we do try to make use of them when we're able. They have quite a long wait list for their behavioral therapy supports as well. But we always refer to them and make use of them as much as we're able.
So Western actually has a master's program in private analysis, which Nicole Neal is director of. And so if you're looking for people who are looking for jobs,
perfect. I just need to have somebody to hire them. That's the challenge. Exactly.
So this was fantastic, actually. It was a great overview, and it really, I think, highlighted the difficulty of transition at the beginning as well. What sort of questions people have for Dr.
Cassidy?
Oh, sure. So why was Rett syndrome initially included in the pervasive developmental disorder? Because outside of the hand area, it really doesn't have a lot else in common.
They all go through a phase after 6 months to a year where they actually associated with the development
because they're touching
language regression.
But if after like 6 months to a year they don't look like they have autism, then why would they be included in the group? Especially since the distinction between psychiatry and neurology is probably an artificial one at this level. But if there is such a thing as a clearly neurological disorder, it would be Rett syndrome. And so whether it should have been there in the first place.
Oh, yeah, and it was a big debate at the time. I wasn't training. It was a big debate. The Canadian perspective was it never really.
Psychometrist that work,
We
Yeah.
do not, no.
because when you can't get an IQ, then I'm going to be using the brief social adaptive scale,
Mhm.
which doesn't require using IQ. What are they able to do?
Mhm.
Okay. How much can they look after themselves?
Mhm.
So, and that doesn't take very long. So you can do that.
Yeah.
But that creates a difficulty, and Joan and I have this argument on a daily basis, that in some ways, that regardless of what a person's IQ is, if they aren't able to function in life because of all their motor problems and other communication problems, in some ways, having a higher IQ might actually be more frustrating.
So a lot of
Yes.
them lose their ability. I was in section. I
Yeah.
still went to
Mentally, yeah.
most minimal,
Yeah.
because she's sort of was maybe by the time they're 7 or 8, they're part-time in wheelchair, by the time they 10, most of them are non-ambulatory. So using any kind of adaptive measure is not always helpful because they can't do anything.
Mhm.
But we know there's an intelligence in there, and the Tony's allowed us to unlock that.
So
If
maybe,
anybody wants to see, there's video of how we perform it. If you do a search, you can find it on YouTube.
yeah, and her mom is not like, doesn't hide that. That's she openly declares if you want to look up Abby Conrum at Rett Syndrome or something like that.
You'll find it.
Yeah.
You see them and you'll find out, and you'll find other people on YouTube. I
Mhm.
downloaded the videos for presentations, seeing people use it.
We asked what happened to one we know when she was traveling to
See that again?
Catamount.
Yes. When she doesn't make enough eye contact. The trick with beginning to use the Tony is that they have to be able to make choices. So you have to get them interested enough in looking at the screen, usually to do something like some cartoon pops up and makes a lot of noise. And you have to sometimes persist at that for a couple of years before they get it. And then when they get it, it tends to take off. So yes, we tried it with her. It's not really effective. We had her in clinic 2 weeks ago. She was way more effective at using it than
Oh,
the
yes.
other reports that she's.
Oh, yes, definitely.
So sometimes
She doesn't know.
parental buy-in.
Have they used it in neurodegenerative disorders? Like I think with ALS or something like that.
Yeah,
Is
so
the idea.
they're looking at eye gaze technology more and more with lots of different populations. The problem is accessibility, right? So, for example,
Right.
in London, we don't have an adult augmentative communication program. So, if you didn't get that device as a child, and even if you got it as a child, typically it's leased, and so they'll only service the lease for a period of time, even after you age out of the pediatric augmentative communication program. So then, if you're an adult and you're looking at that for neurodegenerative disease or anything else, you have to access services either through Kitchener or Toronto. Which, yeah, total sense, yeah. So there's a long wait to access those services because they're the only ones.
Well, I guess as a society, you don't say maybe the cost.
Yeah.
And we don't like to think about it because the reality is that $20,000 what it is.